When you look at the number of high school athletic injuries, 9% of athletic high school injuries are concussions. So, all of us taking care again of sports medicine athletes will certainly have concussion as part of our practice. When is it safe to return an athlete back to sport, to resume sport? And the timing of this return to sport. There's certainly conflicting evidence that we'll talk about, and really recovery of subjective symptom scores. And typically, what we use is a symptom checklist and typically some simple office evaluations, such as a SCAT-6 or a SCOT, is really imperfect. Physiologic dysfunction, motor dysfunction can certainly outlast that of clinical recovery, and especially when the athlete tells us that they're back to their normal baseline. So, sports related concussion is an impairment of numerous components of the CNS, resulting in deficits. So, these are important: the cognitive piece, the postural control, vestibular, oculomotor, cardiovascular, because they all will play a role in symptoms and also something that needs to be addressed when we discuss return of play and proper return to play of athletes. The problem here is that we are probably, most all of us are failing our athletes, and we're returning our athletes to play not necessarily too soon, although in most cases that is probably correct, but we're not doing the proper evaluations to safely return them back to sport. So returning them back to sport before there's full neurological, musculoskeletal, especially MSK is what we're going to address tonight, this evening, and we're returning these athletes with persistent deficits beyond their clinical recovery. So the hazards if we return our athletes back to play, many are very common to us. If we return them back too early, there's an increase of a repeat concussion, repeat injury. And that's always been a big deal for us. And we've certainly gotten a lot better about recognizing when to return athletes back to play so that they're not at this increased risk for a second concussion. But big is this increased risk, again, of musculoskeletal injury. So if we look at NCAA athletes, for example, and we look at their self-reported subjective concussion symptoms, most NCAA athletes will resolve all of their symptoms in 6 days. But we're going to look at studies that, however, will tell us that persistent physiologic and neurologic deficits still persist. So again, as an overall view on looking at some of these studies, the cognitive recovery after sports-related concussion occurs within 5 to 10 days, but there's a delay, a significant delay of reaction time in adolescents and adults. It's shown to return to baseline at 2 months or longer post-injury. Balance, something that we think is the first to recover in our athletes and recovers within, typically, when we do our testing, a BEST test or a tandem gait test, already in within 48 to 72 hours. But many of the studies are showing persistent differences in balance persisting for up to 3.7 years, 6 weeks to 3.7 years. Similar findings for motor impairment, and in the office, we typically test single task, and we should be doing at the very minimum dual task gait, and we'll talk more about that. And the gait analysis in athletes previously concussed have revealed movement instabilities that may be amplified in more demanding sports environments. So we use a variety of assessment tools in the office when we return our athletes back to sport. Symptom reporting probably being one of the most important one. We monitor their symptoms through the guidance and through their duration of the concussion. We look at their time to symptom resolution. If symptoms are extended, we may do even formal neuropsychological testing. And then again, in the office setting, we do this static balance postural control testing. So we use, for most athletes, this graduated return to play protocol. And under this current protocol, this paradigm, an athlete is typically cleared to return to play within 14 days post-injury. So recent evidence suggests that both adolescent, collegiate, and we'll look at professional athletes are at significantly greater risk for lower body injury following a sports-related concussion. And this increased risk is for up to 1 year after a concussion event. Within the first year of returning to sport following concussion, collegiate athletes are up to 2.5 times more likely to sustain a lower extremity injury than uninjured athletes. And why? especially because of this altered neuromuscular control, greater knee valgus, and knee internal rotation during a jump cut maneuver, changes in lower extremity stiffness during a jump landing task. I mean, what do we all think when we see that greater knee valgus, right? Increased risk for certainly ACL injuries. And they've done the studies and they've shown that when we're returning athletes back to play, this is a significant problem with performance after concussion. So here's a study from AJSM in 2019 that looked at NCAA athletes. It was a retrospective study looking at athletes with multiple concussion, single concussion, and no concussion. And the final of the study showed that athletes with multiple concussions, a history of multiple concussions, showed significantly greater odds of a lower extremity and shorter time to injury during those first 3 to 6 months post concussion. Here's an article from 2022 from the Orthopedic Journal of Sports Medicine, also a review type study looking at 4,300 athletes, high school, collegiate, and professional athletes. And the conclusion of the study, again, increased risk of lower extremity injuries at 90 days and 1 year after concussion. And this risk was higher for collegiate and professional athletes. Other clinical studies more recent in this year, 2025, from again, Orthopedic Journal of Sports Medicine, a study by Woodrow et al. Showing significant increase in lower extremity injuries up to 1 year after concussion in young athletes now. So these are adolescent athletes. So adolescent athletes, high school, college, and professional. And here's the professional piece. Also out of OJSM 2025, a study looking at NBA players who sustained a concussion. They found that they're at significantly increased risk, as much as 11 times the risk, for a subsequent MSK injury within a 90-day post return to play period after concussion. Now, this is more recent. So, over the past few years, it's been known, and we've been working at trying to decrease or figure out how to decrease this risk for lower extremity injuries post concussion. But some of the more recent data in these two studies from the Physician Sports Medicine 2024 and 2025 also showed an increased risk of injury for upper extremities. So I think we would all say probably not unexpected. But this was in collegiate football players and also community rugby players that showed this increased risk for upper extremity injury. So here was a good study back in 2020 from the ACSM journal, Medicine, Science, Sports, and Exercise. And it really looked at, are there any good clinical predictors that we could use as clinicians to predict which athletes are maybe more at risk for these post-concussion extremities, be it lower extremity or upper extremity? And really the final result of the study, unfortunately, said that no, there was no demographic, there was no specific injury characteristic for the concussion, and there was nothing that was being done on concussion assessment that could predict which athletes would be at increased risk for lower extremity injury. So there are theories why athletes are at increased risk for this upper and lower extremity injuries. One, impaired motor planning and coordination. Motor planning, something that we do subconsciously, brushing our teeth, washing our hands, whatever it might be. A reduction in the cerebral cortex excitability, so more dulled reaction by the cerebral cortex. Neuromuscular alterations, processing environmental stimuli out on the field, just not processing that information as well. And then we know that there are a difference between the clinicians that take care of these athletes, whether it's the athletic trainer, the physical therapist, the physician, the PA, nurse practitioner, whoever it is that's taking care of these athletes and making a decision about return to play. There's a good chance that we may be using different protocols. So I won't spend too much time on this, but we know that this is an important part of a concussion evaluation is symptom reporting. And certainly athletes have different reasons, maybe not to be perfectly honest about their reports, reporting their symptoms and other things, wanted to get back on the field sooner as well. So this was a good study. We talked about some of the deficiencies that these athletes have post-concussion. So this was a study that was just looking at collegiate athletes, no concussion, but who sustained ACL injuries. And what they found was for many of these collegiate athletes who sustained non-contact ACL injuries had slower reaction times and processing speed, and they had deficits in visual and working memory. And they also looked at collegiate football players and saw that they had reaction times greater than zero point 0.5 seconds, were more likely, 2 times more likely, to sustain a lower extremity sprain or strain over the course of a season. So these are exactly similar findings that we would see post-concussion, this increased risk, again, for injury. So what do we do in the office and why are we failing? Probably the biggest thing is that we're just doing these static positional testing in the office, right? A best test, if you're familiar with it, we just have an athlete standing in a tandem gait. Standing maybe with their feet together, heel toe standing, and one-legged standing. So we're really not provoking much when we're doing that testing. And even a tandem gait test, we're really not doing too much. So our testing is in the office setting is especially very static. So here's one thing. So what could we do? What could we do to be better, to change this? Because we're not good and we need to be better. So one thing that's been shown to make a difference is this dual task gait or gait performance under complex conditions. So this would be someone, for example, doing a tandem gait, maybe a heel to toe gait while they're subtracting sevens from 99, or while they're naming the months of the year backwards, whatever it might be. So they're doing some cognitive talk as well as doing this postural assessment. So this potentially is more appropriate for detecting impaired dynamic postural control. And the study looked at these athletes with concussion after reporting symptom resolution and having normal single task walking, adolescent post sports related concussion, ones that we would have cleared for sport, showed slower walking velocity, shorter cadences, and a decrease in their stride length. So on this is another test that has also been shown to be possibly to make a difference, and also is very interesting what they found. So here was a study out of a physician in sports medicine in 2019 using an intensive physical exertion test as a final return to play measure in concussed athletes. So it's called the GGT, the Gapsky-Goodman test, and they had these athletes perform stationary cycling at a high level and plyometric activities. They looked at over 750 athletes, ages 13 to 25, 60% male, 40% female. They looked at 5 sports. And all of these athletes, when they started giving this GGT test, were all asymptomatic and they had already completed their return to learn and return to play protocols. So these are the athletes that would have returned to sport. But what they found just in this one study was that as many as 15% of these athletes had exacerbation of their symptoms during this GGT test. So clearly, there's 15% of athletes already in a test like this showing that we're clearing these athletes too early, or not doing the proper testing, or not doing the proper work, having these athletes perform the proper rehab leading up to our clearance. So in conclusion, we're not doing well when it comes to return these athletes back to sport. And when we look at risk of musculoskeletal injury, even during that whole first year, 6 months to a year, there's definitely an increased risk in lower extremity injuries. And now we also know upper extremity injuries. We need to be better. So we need more objective criteria for determining when an athlete is ready to resume sport participation. We need better testing, right? Better gait and sport-specific movement analysis. And we need adherence from all of us as clinicians, right? Doing this and affecting when we return these athletes to sport. We need better studies looking at lower extremity and upper extremity movement, biomechanics. So essentially, there's a lot to be done. And again, in conclusion, we need to be better. But I would say to all of us, even at this stage right now, before we return our athletes back to sport after concussion, maybe just try to have them do a little bit more sports-specific training, especially if you have the luxury of having an athletic trainer to really see if they are truly ready to return back to sport. Thank you. And we're going to move on to our next topic. So our next speaker will be Dr. Matt Apicella, and Matt Apicella is a primary care sports medicine physician in the Department of Orthopedics here at NYU Langone. He is only one of around 300 physicians certified in both fields, so not that common to be board certified in sports medicine and emergency medicine. Dr. Apicella completed his emergency medicine residency at Miami Mount Sinai Medical Center, a sports medicine fellowship at the University of Florida, where he worked with the Florida Gators and other elite athletic programs. And Dr. Apicella is going to speak to us about return to sports in athletes with venous thromboembolism. Dr. Apicella, please take it away.
Awesome. Thanks, Dr. Cardone. Um, so I think I've assumed control here and we'll kind of click through. Perfect. Awesome. So we're going to talk about this deep vein dilemma, right? So treating VTEs in athletes and how that treatment goes and kind of recommended guidelines on return to sport. And while there is some controversy here, there are some general principles to know and when to recognize and how to appropriately work that up and kind of guide these athletes back to their sport, right? So we'll kind of jump right into it. Um, so I have no financial disclosures for this talk. Um, in talking about VTEs, it's important to understand that this encompasses both deep venous thrombosis, which is a DVT, and a pulmonary embolism, right? We're going to focus more so on treating the DVTs, but understanding that this can ultimately progress to a pulmonary embolism, which ends up being more of an emergent diagnosis. It's important to remember that pathophysiology that in turn creates these clots, right? So if you remember from medical school training, Virchow's triad is kind of that general core principle that we think of the clot formation, right? So that combination of hypercoagulability, venous stasis, and endothelial injury that can all lead to the formation of a thrombus. And while this is definitely a little bit more common in the general population, it does affect our athletes, right? The literature supports that about 1 in 1,000 athletes are found to have a VTE and does carry a high risk of morbidity and mortality. So it's important to kind of recognize and know the appropriate kind of treatment and workup for this. And then further kind of diving into it, right? It's important to understand that there are different risk factors that go into VTEs. And so we kind of break them up into this inherited risk factor and this acquired risk factor, right? So your inherited risk factors are going to be more your natural deficiencies in your anticoagulants. If you have any underlying genetic deficiencies or factor five Leiden mutations, and your acquired risk factors are going to be those ones that the athlete or patient acquires throughout their life. So maybe some malignancy, antiphospholipid syndrome, extrinsic risk factors like drugs, smoking, obesity, pregnancy, surgery, or major trauma. And then there's some specific kind of athlete specific risk factors that are important for us to recognize, right? And that kind of highlighted here and how they fit into that Virchow's triad. So, one, thinking about venous stasis in our athletes, right? So, athletes, as we know, have a lower resting heart rate and often lower blood pressures, which puts them at risk for more venous stasis. And they often undergo long travel trips. They may have uh, surgery that puts them at risk for more venous stasis that can put them at risk for developing blood clots. They might be a little bit more hypercoagulable because they're more prone to bouts of dehydration or episodes of overtraining. If they're a female athlete who's taking oral contraceptives, just like in our general population, they may be at a higher risk for hypercoagulability. And then if they're repeatedly undergoing changes in altitude or using any hypobaric chambers, that can put them at risk as well. And then thinking about kind of more vessel wall injury, right? So athletes undergo a lot of repetitive stress, a lot of repetitive injury, and that can put you at risk for endothelial wall injuries. And so together, these are kind of more of those athlete specific risk factors that we have to be aware of and have to constantly think about. And so then the important distinction becomes whether this is a provoked event or an unprovoked event. And the reason why this is important is because it's going to guide our treatment when we're thinking about treatment options for these athletes, right? So a provoked event is going to be one that has a strong transient risk factor. So in our general population, we generally think about these as some sort of major surgery, some sort of major trauma, whether they've been hospitalized or immobilized for a period of time. And then in our athletes, this is going to be more so a DVT that's associated with one of those specific risk factors that we talked about. So some sort of event that then leads to them developing a blood clot. An unprovoked DVT is exactly what it sounds like, right? So an event that doesn't have a clear trigger, um, nothing that you can truly point to say that that likely caused their injury. And then obviously important to recognize the clinical presentation and how these are going to present. So they're typically going to present with this unilateral extremity plane swelling, maybe some erythema, and important to have a high degree of suspicion because oftentimes these can mimic a muscle injury or a muscle strain. So making sure you're having that in the back of your mind to always consider. Obviously, pulmonary embolisms, just to kind of go along the spectrum, are going to present with more significant symptoms of chest pain or shortness of breath, tachycardia and hypoxia. Uh, and so when we think about lower extremity DVTs, right, it's important to be familiarized with the vasculature and understanding the differences between a proximal and a distal DVT, right? So an easy way to think about it is kind of thinking about above the knee being more of a proximal location and below the knee being more of a distal location. And this again is going to help us kind of guide management and treatment going forward. And so it's important to when they look at kind of systematic reviews and in what athletes are at higher risk for these, it's shown that we see these more in soccer players, endurance athletes, martial artists, and in soccer players and martial artists, it could be due to that repetitive lower leg trauma that they're experiencing throughout their play or throughout their sport. Endurance athletes like runners, it's going to be more that repetitive micro trauma or sometimes that venous pooling as well too that can put them at a higher risk. And then some of the symptoms that we already talked about. For upper extremity DVTs, it's important again to familiarize yourself with the deep vein structure as well as the superficial vein structure, right? Because superficial vein thrombosis are not going to be treated the same and most oftenly are not going to require significant anticoagulation or treatment. But understanding where these deep veins are located um, and when to recognize whether an athlete has a deep vein thrombosis of the upper extremity. Looking at review studies that look at the pathogenesis for these upper extremity DVTs, it's actually more commonly a secondary cause in the general population, right? So something associated with catheter-associated thromboses, cancer-associated thromboses, or uh, shoulder trauma, or surgery of the upper extremity. But in our patient population, so in these athletes, we're thinking about these primary causes. So more so venous thoracic outlet syndrome or effort related thrombosis. And they also kind of lump in this category of just kind of idiopathic, right? So kind of focusing in more on these effort thromboses is one disease entity to be familiarized is this Paget-Schroeder syndrome, right? So this is where you have a clot that forms in the subclavian vein, and it's going to be more common in these athletes that are involved in these repetitive overhead activities. Most commonly seen in the review papers that I looked at in baseball athletes, specifically pitchers is where it's seen more so, weightlifters as well, and then less commonly in but still more than other athletes in swimmers, football players, basketball players, volleyball players, and wrestlers. Really, you're going to consider it more in these athletes that have that repetitive overhead activity that can put them at risk. It's going to present with more kind of acute pain and swelling and even discoloration to the area of the upper extremity. And you can see these dilated collateral veins, which is called an Urschel sign. And then when we're considering this diagnosis, it's important to understand the workup and the evaluation for it, right? And understanding the sensitivity of our testing that we do for it. So we're all very familiar with ordering a venous duplex ultrasound when we have consideration for this, but understanding the sensitivity, it's very sensitivity for proximal lower extremity DVTs and pretty sensitive for these upper extremity DVTs as well. Where we start to lose some of that sensitivity is going to be in these isolated distal DVTs of the lower extremity. And that's where if you have a high degree of suspicion where doing multiple serial ultrasounds is going to be able to eventually pick that up and be able to help you with that diagnosis. as long as you maintain that high degree of suspicion. Obviously, if you're more concerned for a pulmonary embolism, the gold standard testing is going to be a CT pulmonary angiogram. And then laboratory testing is where there comes to be a little bit of a gray area, right? So common tests that are going to be ordered when you have an athlete with this are going to be a CBC, ESR, um, coags. And then when you're thinking about when to do thrombophilia testing, right? The literature supports doing it in young athletes or young age individuals who are less than 40, patients who have a strong family history of VTE, or a VTE with weak provoking factors, or in the event of a recurrent VTE. It doesn't necessarily change our initial management, which we'll talk about, but in most athletes are going to consider doing this thrombophilia testing to see if they have any other underlying kind of inherited risk factor. And then when we start to think about treatment for it, right, which is the focus of what we're focusing in on tonight, right? Um, the general recommendations for treating a DVT in a patient or an athlete is understanding whether this is provoked or unprovoked, right? So in a provoked proximal DVT, so those ones with those strong transient risk factors, the treatment is really going to be a 3-month course of anticoagulant therapy, and the treatment of choice is going to be one of these direct oral anticoagulants, so your DOACs. And that's truly because they have a shorter half life, they have more predictable pharmacokinetics, and allows for greater flexibility with treating these athletes. Um, for a provoked distal DVT, there is some leeway here. If they're asymptomatic, you could consider close observation with serial ultrasounds to see if that clot reabsorbs. Um, but if they're symptomatic, meaning they have any sort of pain or significant swelling, then the recommendation is still to start them on anticoagulation. And then for unprovoked DVTs, this is where it gets to be tricky, and where they may need indefinite anticoagulation, and ensuring that you have specialists on board to help you out, such as hematology, is likely going to be needed in these kinds of scenarios as well. And then when we talk about acute upper extremity DVT, so again, in that Paget-Schroeder syndrome that we talked about, the recommended treatment really is going to be this catheter-directed thrombolysis. It's been shown to be most effective if it's done within the first 14 days of symptom onset. Um, and then it's usually followed by a surgical thoracic outlet decompression, which is going to be a resection of that first rib. And in studies where they've looked at multiple athletes, one of which that I looked at in about 140 athletes in a journal of shoulder surgery, they saw athletes that were treated with surgical intervention had about 84% likelihood to return back to their original lifestyle and sport activity, versus athletes that were treated with only anticoagulation or direct thrombolysis. Only about 40% of those were able to kind of return back to their original sport activity level. So the literature is really supporting pursuing more of this surgical decompression after the directed thrombolysis for these patients. And then return to play guidelines, right? So it's really important to understand that there's limited high quality evidence in the way that this is typically done. It's typically an individualized um, return to play program for each athlete, right? And so the idea behind doing this is that understanding that you don't want to allow them to go back to any sport while they're playing, while they're on anticoagulation, for those first 3 months. And really, most of the recommendations say that you shouldn't go back to exercise within the first 2 to 3 weeks when starting the anticoagulation. And that's to allow that clot to stabilize. They've done randomized control studies to look at the exercise in athletes who have started on anticoagulation. And really, at about 5 to 6 weeks, it's definitely shown to be safe. But some more expert opinions and review papers have shown that 3 weeks is probably about safe for these patients. After 3 weeks, they can resume non-collision fitness training. So anything where they're not going to be at risk for having a collision injury. And then after 3 months of continuous treatment with resolution of symptoms and without any residual clot burden, they can safely transition off of anticoagulation and resume their sport activity. Now, in the case of athletes that may need indefinite anticoagulation, right? So these are going to be those unprovoked VTEs in athletes, or those athletes who are have a recurrent VTE, right? That's where the the recommendations are definitely limited, and a lot of the research here is more so done with position papers and expert opinions on how to do this. And one of the mainstays behind this is understanding that this has to be a shared decision making process between the athlete, the team physician, um, and involving specialists on board such as hematology and cardiology is recommended, and making sure that they understand through an informed consent the risks of being involved in this. And it's there aren't really recommendations on essentially what to do with this, but the position papers that have been put out have shown that they recommend a strategy that can be done. And there has been some athletes that have done this in professional sports successfully. The first line choice that they recommend is still these DOAC medications. Low molecular weight heparin is an alternative as well. Has a little bit of a shorter half-life than the DOACs at about 7 hours compared to about 12 hours with the DOACs, and some athletes have done that in the past. The way they recommend doing it in these expert opinion papers and these position papers is a strategy that's developed for non-contact sports, right? So for swimming, badminton, moderate intensive running, they recommend on days where you're going to do a prolonged practice or a game day that they would skip their morning dose of anticoagulant. And then if no significant trauma occurs, um, they can next scheduled dose can be resumed. But if a trauma does occur, then they would hold it for about 24 hours. In contact sports, right? So sports like cycling, boxing, rugby, baseball, soccer, hockey, it's still recommended to undergo this twice daily DOAC regimen. But on game days or contact practices, no anticoagulation would be given at all. And then, regardless if there is a trauma or not, they're still held for about 24 to 48 hours after a game or some sort of contact practice. And that's due to the risk of a potentially silent injury. And again, while is a suggested protocol, there's other studies that are looking at kind of the pharmacokinetics behind doing some pharmacokinetic testing to see when enough of the drug has left the system when the patient can kind of return back to the sport safely. But this position paper offered about this 24 to 48-hour period. Um, they recommend having checklists done with the athlete after practices, and before games and after games as well too, to kind of keep track of their symptoms. And like I said, there's been a couple of occurrences of this done specifically in the NHL. Um, Several years ago, there was a couple of athletes, one that used low molecular weight heparin safely, um, and some other occurrences too, but it is definitely less common. And that's pretty much it.
All right, Matt, Dr. Apicella's super talk. Great topic, and I think fortunately, we don't see these that often in the office setting, but we definitely do see them. So really great information, and I know for me, just like you said, it's like about getting some of the more specialists involved, and but really a great talk, great information. Thanks so much, Dr. Apicella. Our next talk is on controversies and return to sport after ACL reconstruction. And joining us is Dr. Ariana Lott. And Dr. Lott, a sports medicine orthopedic surgeon here at NYU Langone, obviously specializing in sports medicine with a background as a former ballet dancer. Dr. Lott is an expert in minimally invasive surgeries of the shoulder, hip, and knee. She completed her residency here at NYU Langone, followed by a sports medicine fellowship at University of Pittsburgh Medical Center, worked with the Steelers and the University of Pittsburgh sports teams. She's trained internationally in hip arthroscopy, published over 50 papers on sports injuries, particularly in athletes and dancers. It's really a pleasure to welcome Dr. Ariana Lott.
Mhm. Thank you. Thank you for having me. Um, so today I'm going to talk about controversies in return to sport after ACL reconstruction, which is something um, that I see in my office all the time. Um, So, in terms of the epidemiology of return to sport after ACL reconstruction, whenever we see a patient who undergoes ACL reconstruction, we all say, our goal is to get you back to doing everything you want to do and return back to sports. But when we look in the literature in terms of the numbers of our patients that really get back after ACL reconstruction, overall, about 67 to 87% of patients return to any sort of sport postoperatively. And then in the general population, if we look at who returns to their pre-injury level, it's about 40 to 60%. So a lot lower than sometimes that we quote. And of our elite athletes, only 83% of them are really returning to their pre-injury level of sport. And 20 to 30% of patients actually sustain a second ACL injury, whether that's the same side or the contralateral side. And so, what are the criteria that we're using to clear patients to return to sport? And so this was a recent review that kind of went over all of the different tests that different studies mentioned that people were using in terms of return to sport. And they looked at a bunch of different studies, and they said that time was included as a criterion in 85% of the studies, with over 80% of studies allowing return to sport testing before 9 months. But whether or not these return to sport tests are valid, or even if they predict successful return to sport, is really largely unknown. And then in this more recent systematic review, in the summary statement, the authors cite that optimal return to sport criteria have yet to be determined. Future prospective studies should focus on comparing the different times and milestones currently available. So more questions. And then if we look at the Moon Knee group, which is one of our big study groups in orthopedic surgery on ACL reconstruction and getting people back to sport, they even cite that there's no validated return to play criteria. None of them have been proven to be statistically valid. They recommend evaluation by a medical professional with return to sport experience. And then they mention that everyone is different. So, still a lot of questions. And so if we have this patient that, a patient of mine, she's a 16-year-old female. She presented with an ACL injury that she sustained while playing soccer. She underwent an ACL reconstruction with bone patellar tendon bone autograft. She had a medial meniscus repair, and she also had a lateral extraarticular tenodesis performed. And so when she comes and asks me, when can I return to sport? It's that's where there's the controversy, and that's what we're going to talk about today. And so, how do we determine when she can return to play? And so, what we do know is in terms of timing versus of return to sport, we look at our early return to sport versus the late return to sport, and it's been shown repeatedly in the literature that if you return to sport less than 9 months, you do have a higher re-injury risk. This was a study of 159 athletes, young athletes, so 15 to 30 years old. And those patients that returned before 9 months, they had a nearly 7 times higher rate of a second ACL injury. And interestingly, the researchers found that there was no association between symmetric muscle function or quad strength, which is something that we often test. Furthermore, in this study that tracked 106 pivoting sport athletes, the re-injury rate was significantly reduced by 51% for each month. Return to sport was delayed until 9 months after surgery, and then after 9 months, they didn't see a significant drop off. And then the question is, if we're waiting 9 months, how do we decide if it's 9 months? Should we wait a year? Should we wait 2 years? And some even studies are saying, like this one below is saying, should we even return them back at 2 years? So where do we where should we set that threshold in terms of timing? And then we have our time-based return to sport criteria versus more criteria-based return to sport testing. And so time-based would be the 6 to 9 months that some people offer, but is it better to do it by more criteria-based testing? That makes more sense, but is that really true? So some of the criteria that we look at are limb symmetry, hop tests, strength tests, because some studies show that you can even see quadricep deficit strength, even in 40% of patients at 9 months. So maybe we don't really know what we're quite looking at. And so the question is, do these metrics actually predict that it's okay for these athletes to return to sport? And so what are some of the issues with some of these functional testing? So a lot of these are for our hop testing, whether it's single hop testing, triple hop testing, timed hop testing. There's a whole series of hop tests that people have used. Um, People have noted that also limb symmetry may mask if you have an issue with both sides. So if you have a young female athlete that has, valgus dynamic landing jump mechanics, she may have that on both sides. And so their hop test may be similar. In addition, you don't really the compensatory patterns and the movement quality are not accurately assessed by some of these return to sport tests. So that's where people have some concerns about these functional tests that we've been relying on. And if we look at this study that was performed of 234 patients over 2 years, they found that there was a 28.4% subsequent ACL injury in those patients that returned to sport. And they found that greater knee extension symmetry at 6 months actually increased the probability of injury. And those patients who returned less than 8 months, every 1% increase in quadriceps strength at 6 months increased the risk of re-injury by 2.1%. So other data coming into this of just kind of more confusing about what should we actually be using in terms of trying to clear our patients to return to sport. And then we have all these tests, and then do these tests actually work? And so this was a study of 419 patients. That sustained a 12.2% second time ACL risk within 2 years. And they found that there was really no difference in passing rates for the different return to sport tests and patient reported outcomes for those patients who suffered a second ACL injury for those who didn't. And so I think a big component of this that we're also starting to realize is a lot of psychological readiness. And psychological readiness is the fear of re-injury, and whether our athletes and quantifying that has been something that people have been trying to determine. And so there's been developed what's called the ACL RSI scale, and this has been validated, but it isn't widely used by everyone. But it really draws on the conclusion that physical clearance is not the same as psychological clearance. And so this was a prospective study of 129 patients, and you see the ACL RSI score questions that are listed on the right hand side of the slide here. And those patients that had a score of less than 47, that indicated that they were at risk for not returning to their sport, with an ROC curve of about point 0.7, with 85% sensitivity and 45% specificity. And in this study, they found that the functional test didn't actually predict the return to sport, but in fact, the psychological did. And so then the question, as a surgeon, are there surgical factors that play in terms of getting people and athletes back into return to sport? And so in terms of graft choice, was BTB better for return to sport, hamstring, quadriceps? So in the Moon group, they did show that the BTB had a lower failure rate in younger athletes. And then there's been, recent literature about lateral extraarticular tenodesis or any sort of lateral augmentation procedure in the possibility of increasing the return to sport rates, especially in our young athletes. And so why do we wait these kind of 9 months? And so we've shown that in the lab, the ligamentization of the graft and going back to becoming a ligament from a tendon takes about 12 to 24 months. And some studies have even shown that on the MRI, the graft signal does remain abnormal for over a year afterwards. So it does take time and biology for this to happen. Um, and so where are we looking to next? So in terms of future directions, so in an ideal world, we'd have like a personalized return to sport algorithm that are sport specific. Um, we need to look furthermore at biomechanics, imaging, and some integration with psychology and psychological readiness. And then it would be great if we had some prediction models and we could, use the Moon registry or some of our larger database studies to kind of help us with that. So, in terms of putting it all together, what do people tend to use in their practice? So, this was a recent study in arthroscopy, and this was the algorithm that they recommended, that the authors recommended. And so, one was time since surgery of at least 8 months. Two was use of at least two functional tests. Three was use of a psychological readiness testing. And then four, quadriceps or hamstring strength testing. And then my modification is I personally don't let patients go back before 9 months. That is based off of the some of the studies that I presented earlier, also the time of ligamentization and taking that time. I think waiting 9 months helps with that. So that's just my modification to their algorithm. And then in conclusion, this is obviously remains still a controversial topic. Timing, testing, psychology, biology all matter. And really having an individualized and evidence informed approach is really key to this. So thank you so much.
All right, Dr. Lott, thank you so much. Yeah, another wonderful talk, really great talk, great topic. It really, it almost reminded me a little, and we could talk more about it later, but a little bit like the concussion, where we were just returning athletes. We talked about the increased risk for injury in those first 6 to 12 months. A little bit similar here, where we don't have good maybe physical data about good physical tests. But like you said, I think here especially on like concussion is more than just physical testing and strength. You know, it's a multifactorial component that really complicates it. But really great stuff. Thank you. Okay, our next speaker is Dr. Daniel Kaplan, and Dr. Kaplan is going to speak to us about return to sport after surgery for shoulder instability. And Dr. Kaplan, a sports medicine orthopedic surgeon here at NYU Langone Health. Before coming to New York, Dr. Kaplan served as a team doc for the Bulls, Chicago Bulls, the White Sox, and Fire. His expertise spans minimally invasive arthroscopic procedures, complex joint reconstruction, shoulder, hip, knee, and elbow. And in addition to Dr. Kaplan's clinical work, he's a prolific researcher, over 150 publications. His work continues to shape both surgical techniques and conservative treatment strategies in orthopedic sports medicine. And I always kid him that I really, and I'm not sure I'm kidding, but because of where he practices at Bellevue, maybe does more ACL reconstructions than anybody in the country. But anyway, it's a pleasure to have Dr. Kaplan speaking to us about return to play controversies, shoulder instability. Dr. Kaplan.
Thank you, Dennis. Sorry I'm coming to you guys live from this amazing lobe auditorium bacteria because I was just doing a revision one of these cases. So, bringing real life expertise straight to the webinar. So outline, we'll do anatomy, how these injuries happen, first time dislocator management, some non-op treatment, some surgery, and then specific controversies. Now, the problem with all of these controversy talks is always you're probably going to leave with a lot more questions than answers. Ariana did an incredible job giving you an algorithm. I'm not going to do that because I'm just not as good as her. Also, because there's not as good information here, and a lot of it is experience, super patient specific. So it gets really hard and nuanced to give more algorithmic versus more generalizations, which I think will be helpful on how you can approach things. So, talking about anatomy, this is one of my favorite pictures in the world. So, there's a lot of things that keep the shoulder stabilized. So, starting with bony constraints. So, the shoulder is by far the most mobile joint in the body. That's great. That lets us go like this. Raise your hand to ask questions of people like me, very knowledgeable. However, the problem with that mobility is that comes at the sacrifice of constraint. So even though we call the shoulder a ball and cup, it's a little different than the hip. The hip is a true ball and cup with a concavity that where you get bony restraint. The shoulder, conversely, is really just almost like a dish rather than a cup. So the bone provides only 20 to 30% of that restraint. Then, as you can see in the picture here, you have a labrum. That labrum increases the depth of that concavity by as much as 50%. I don't know why I'm using my mouse because you guys obviously can't see that, but you'll have to take my word for it. Then there's the joint capsule, which is attached to that labrum. And then there's the glenohumeral ligaments, which you can see in the center there. For our purposes, by far the most important is that anterior inferior glenohumeral ligament. That's the one you see at the bottom. That's what helps us in that flexion or abduction external rotation position from the humeral head coming out. So in that 90-degree position. Now that those were passive. Passive restraints mean they're always working. They don't need muscles to fire. Think of them the way like bones or ligaments, they're always taut. Then you have your dynamic. So that's going to be a repeat because it didn't tap you over. But what you can see on the right is you can see our rotator cuff muscles. So our rotator cuff is the primary dynamic restraint. There's those four muscles, the supraspinatus, infraspinatus, teres minor in the back, and then a subscapularis in the front. What those do is those provide what's called a concavity compression. So beyond helping us lift our arm, when those rotator cuff muscles and tendons are firing, they help keep that humeral head pushed against that glenoid dish. What that does is that helps make up for the fact that even though that's a shallow bony concavity, this pushes it against it to give us that extra restraint, allowing us to rotate. That's why if you have a massive rotator cuff tear, you try to rotate, you don't have that concavity compression. Nothing's holding that bone against the humerus against the glenoid, and then the ball starts moving in ways preventing your shoulder from working. So now that we understand a little bit about what's supposed to work, let's talk about when things don't. So, in terms of injury mechanism, the worst or most at risk position is what's called when your arm is abducted, externally rotated. This is the worst thing you could have it. Then, think about a football tackle. So, someone's like this, someone pushes posteriorly on the humeral head or on the humeral shaft. That's going to bring that humerus forward, as you can see in the picture on your right. When that ball moves anteriorly, it's going to do several things if it's going to dislocate. One is it's going to tear that labrum in the front. Two, the back of the humerus, as you can see here, is going to hinge on the front of that glenoid. Two things are going to happen during that. One, as you see in that picture, a little divot in the humeral head is going to form. That's going to increase your risk of dislocating in the future. That's called a Hill-Sachs lesion. And then two, some of that bone of the glenoid is going to be lost because the humeral head is in strong force hitting against it. So now you have a torn labrum, torn capsule and ligaments, loss of anterior bone of the glenoid, and then a little bit of loss of bone on the humeral head. So, 3 to 4, depending upon the extent of the injury. So a lot of things go wrong, which makes us have to keep people out for a little while. So this is how that happens um, in sports. In terms of what we do for it. So for a lot of us, if you're a sideline doc, like a lot of us have experience with, if possible, you're going to try to reduce this dislocation on the field. First rule of orthopedics, whenever you can, reducing a joint is going to usually make everything else better. So if they're have a problem with their neurovascular status, the first thing you want to worry about is getting everything back where it's supposed to be so nothing's pushing on something that shouldn't. If you're on, like I said, if you're in the sideline field, trying a reduction before an X-ray is reasonable. If you're more in a medical center, then it's much more reasonable to get the X-ray first, understand the type of dislocation, where it is, and then do the reduction in a controlled manner. In terms of immediate follow-up, which is probably going to be the most relevant for us. So for a shouldered instability, you do want to immobilize them, but not for an extended period of time. Some patients want to stay in that sling and live there because they just had a very traumatic event. Ariana or Dr. Lott was just talking about the psychological readiness, which is going to be relevant for us too here. This is a real traumatic event. They were doing something they've done their whole lives. They playing football, going for a catch, something they might have been doing 15 years, and for the first time they had this what seems like a catastrophic injury to them. So there's a huge psychological component to it. They're going to want to live there, but we need to get them moving. That's part of our job. So yes, we do want them in a sling for about a week. However, after that week is over, we really want to get them moving with first physical therapy and then a structured rehabilitation program. We do want them to see in some sort of ortho provider for follow-up for physical therapy and an advanced imaging follow. This is one of our controversies that we'll talk about. One thing that I would really want to encourage everyone not to miss, because we see this all the time, is one, neurovascular injury. So when I was It's just starting out practice. Not that I'm so far in, but I wasn't expecting to see so many nerve problems after dislocations. Now, I thought, you read about that, you see that question in a textbook or on a test, but then you see so many dislocations without nerve problems. I just thought it was something that could happen, but the incidence was fairly low. But I've actually seen some pretty catastrophic nerve injuries so far where people have severe brachial plexus palsies where they can't even lift their wrist, complete wrist drop after what seems like a simple dislocation. So, if you see them in the office, they're in the sling, they're saying, yeah, their pain's well controlled. If you don't do that neurovascular exam, ask them to move all their fingers, move their wrist, you could easily miss that. And then you have them go start PT and they follow up 2 weeks later and say, yeah, my shoulder's moving, doc, but I still can't move my wrist. And then you've just lost time to help move that injury in the right direction. So that's something to consider. And then this one's a little outside of the realm here, but it's just so important. We're talking about athletes, we're talking about younger patients. This has that cascade I talked about where the primary lesion is going to be that Bankart or anterior labral tear. Older patients, think over 40, if they have a dislocation, probably after a fall, you have to be worried about the rotator cuff. I have seen many, many patients in my office come after dislocations where it have been ignored. It's been 3, 4 months where they can't lift their arm anymore. And they're like, yeah, someone just kept telling me to do PT. I've been doing PT, hasn't been working. What's going on is they have a massive rotator cuff tear and no one got an MRI. So for a younger patient that you're just trying to in season get back to play, I think the decision to get an MRI after a shoulder dislocation is very controversial, and there's points on both sides. For an older patient that had a dislocation, I would encourage every provider and everyone thinking about practicing medicine to get that MRI after a first time, because that could be the difference between an easy arthroscopic surgery and a reverse total shoulder replacement in a relatively young person. So let's get to our first controversy. So in season return to play after a first time shoulder dislocation. So there's a few things to consider. The pros, well, early return is possible. So if you're like in week 2 of a football season and they want to, they're a senior go before last year before college, they want to play, you can do that. You can probably do that in after 2 to 3 weeks, which we'll talk about. The risk of that is there's a really high risk of recurrence. So this is one where you really have to take the patient, talk to them, risk benefits, share decision making. In terms of what that recurrence risk is, well, it's probably most of the people we're talking about today. So it's worst in patients who are less than 25, and it's worst in contact athletes. In terms of what we can do here, there's a one of the Sully braces. What this theoretically does is it keeps the shoulder in out of that position of risk, so it keeps it away from that flexion abduction position. I'll be honest with you, there's very limited evidence for that. It gives, in terms of psychological readiness, it gives people a supportive feeling. It does theoretically make sense from like a face validity standpoint, where if your shoulder can't go here, why would it not? How could it dislocate? But in reality, study after study has been at best mixed. So yes, I would put a football lineman or something in this to prevent a dislocation. I would tell them I'm not sure if it's going to work, but they're going to feel better in it. And so in terms of return to play, what to think about, um, so operative versus non-operative. So in that, this is the second side of that coin. So for in season, we're generally going to try to treat non-operatively, get them back, but there is growing evidence that treating the first time shoulder dislocation operatively has value. So in terms of non-op pros, well, you avoid surgery. You get there's risk with any surgery, even for me, and no matter how good I am. The faster return, and the con, higher risk of recurrence if you treat non-op. Surgery wise, pros, well, there is a lower risk of recurrence. You're probably preserving their joint because every time your shoulder dislocates, you're damaging your cartilage. So that's putting you at risk for long term arthritis. And studies actually show higher ultimate patient satisfaction when they're treated. Cons, there's all the risk of surgery and particularly missing the rest of the season. Currently, trend wise, we've been trending more and more towards surgery. Is that driven just by me trying to make as much money as humanly possible? Maybe. But it does seem like the literature is supporting more and more stabilizing it. This is beyond this talk, but the surgery is easier after a first time shoulder dislocation than after a 10th time shoulder dislocation. So that's just something to think about. In terms of what your surgical options are, and this is super outside the realm of this, but just to give people an idea, there's a soft tissue surgery, which is repairing a labrum, which you can see on the top right over here. This tissue is lifted off the glenoid bone. You can do something called a remplissage, where you fill some of that bone in the back, and then that helps decrease your recurrence rate. In terms of criteria to return, there's pain-free range of motion, strength drills, which we'll talk about, and then timing. Traditionally, it's been 4 to 6 months. A more accelerated push, which is 3 to 4. Now, the real evidence gap is there's a limited high-level data, so it's about functional testing, which Dr. Lott started talking about for our ACL, which we'll talk about here too. So this brings us to our next controversy. So, what a remplissage is, this harkens back to what we started for in the beginning, when there's a big defect in the back of that humeral head. That can increase your risk of dislocation. So what you can do is you can fill that defect, as you can see in that bottom right picture, with the capsule and the infraspinatus tendon into the back of the bone. That's great. That limits your recurrence. But for our overhead throwers, that might decrease their velocity. That might limit just a hair, a couple degrees of external rotation. For you, me, a football player, probably doesn't matter if you lose between 3 and 10 degrees of external rotation, which is what studies show. But if you're a pitcher, if you're a shortstop, if you're an outfielder, that could be the difference between a scholarship and, giving up baseball. So in remplissage and overhead athletes is still a bit under investigation. We have very limited to no high level data, but this is something that we try to avoid if we can. Other surgery procedures. So then there's some, if you're before we talked about just fixing some of the soft tissue, here we're fixing the bone. So if the bone, you can either do something called the Latarjet, which is a bony procedure, or distal tibial allograft, which is from a cadaver. Picking between those two doesn't super matter. What you're doing is for these patients typically who have significant bone loss. So you're talking about 10, 20 dislocations. A little bit longer to return, 5 to 6 months. Overhead athletes even more, because we have to be careful about the forces they're putting on. But what we really care about is our next controversy. So it's the role of imaging. So here in the top two pictures, you can see that extra bone that's been placed on the front of the shoulder. There it's held with a fixation device, 2 buttons. And in the beginning, that's 2 weeks post-op. So you can see there's a cleft between the native glenoid and where that bone is. Then if you look 6 months post-op, so they got a repeat CT, you can see that cleft is gone. So that is what's called an incorporated graft. So now that is healed. The question is, so that's great. That makes you feel better. That makes the athlete feel better. It makes them feel a little more confident that they can go back to whatever sport they're playing. But the question is, does everyone need that? Do you need that confidence to show a healed graft? Can you just go based on timing? The question is, what is the value? So if it's healed, are you automatically going to let them go? If it's not healed, but it seems like there's a fibrous union, are you automatically going to hold them out? How are we incorporating that? That's something I think most of us don't know. So that's just something we have to think about. The big question, I think, for all of these things is exactly what Dr. Lott was getting at with ACLs, which is time versus function. So after any shoulder, time helps get for healing after surgery anyway. So it's easy, it's standardized. You can say, 4 to 6 months for soft tissue, 5 to 6 months for a bony procedure. That's easy for you to follow. That's easy for the athlete to get that criteria in their head. Okay, I'm going to go, have surgery tomorrow. About 6 months from now, I'm going to be able to start getting back in the game. That's helpful. However, the problem with that is incredibly, obviously not individualized. Everyone patient is different. Their sports are different. Their demands are different. Their psychological readiness is different. So given some sort of just standardized time is going to be really limiting to getting the most for our patients. So then you could do the opposite, or at least, the flip side of that coin, which is functional. So functional would be based on a series of criteria. It's going to be the same criteria that we would just use to get to return after non-operative management. So that criteria would be full painless range of motion, full strength, able to start returning to sport-specific activities. So if you're a wide receiver, think being able to safely, comfortably reach out to grab a pass. Then moving on to non-contact playing, then contact playing, and then eventually full go for games. That's going to be the same rough functional algorithm, whether you're just dislocated for the first time and you've been out for a week, or if you're coming back from surgery. It's always the same thing: range of motion first, then strength, sport specific drills, non contact, contact practice, game. About 6 steps. Um, that is one of the things we don't have an answer to. Much like Dr. Lott, I do both. I do have a time component, and then I use that functional readiness or those criteria to make sure they're getting along on that time frame. So if they can't do those things, even if they've had their 6 months, I won't let them back. The problem is really the converse. So what do you do when someone at 4 months can theoretically reach all of those functional criteria, but you're just not sure about the healing because it's a little early based on the current evidence that we have? What do you do about that? Me, I'm relatively early in my career. I still keep it pretty conservative, and for most things, I keep them out for probably about 5 to 6 months or at the earliest. Maybe some more established, gray-haired surgeons might be a little more aggressive, let someone get back earlier. It would depend a little for me on the circumstance. So if you're just a high school kid who got hurt and you're trying to get back for your senior season, but I played football in high school, I can promise you whether or not I got back a week earlier is not making a difference for me, my team, or my future. Like if I had that orthopedic surgery, I would, my surgeon would have kept me out. I would keep that version of myself out. However, if it's the opposite, if it's a college kid trying to get a scholarship, a few weeks here or there might make a difference. That extra month might be the difference between being seen by that scout or not. There, you again have to use that multidisciplinary or patient-centered approach. Talk to them about the risk and benefits, and really, put it in their hands to a degree while giving them the education to make an informed decision. The next controversy, let's say they meet that functional readiness and the time readiness is psych. So, like we alluded to in the beginning, having this sort of dislocation event can be incredibly traumatic. Like I said, you do something you've done your whole life every single day, and then one day the worst thing in your world happens, and your shoulder pops out. You have to be rushed to the emergency room. You get anesthesia. You get put in place. You're put in a sling. That's terrifying. So coming back from that can be really hard. The last time you did this happened, and now you're trying to play basketball again for the first time in 6 months. So assessing someone's mental readiness is very difficult. There are some validated tools. There's something called the shoulder instability assessment tool or return to sport index. This is, I would say, getting increased use. I don't know that it's fully ready for prime time yet in terms of being the end all be all of letting someone return, but it's at least something to hang our hat on to let the patient know we're thinking about it. They should think about it. And then it is something that I talk about to them as they are getting ready back to sport. Some are chomping at the bit and can't wait, but I've been surprised by people who I would have thought would have been, counting down the days to play, and then they're the ones really pushing the brakes. So it's really hard to know what your patient is going to feel, and I think you just have to approach that with an open mind and compassion and understand where they could be coming from. So in terms of future directions, I think coming up with more objective physical tests. One thing that Dr. Lott had at her disposal for her ACL patients, which was great, was that the single leg hop test, the quadricep strength test, or side to side difference. Those are at least, while not perfect, like she said, at least there's something. There's something that you can hang your hat on, some sort of objective criteria to give a patient to say, all right, I need you to be at least this for me to feel comfortable. For the shoulder, we don't really have that. You can do like side to side, cuff strength, but that's always going to be pretty similar pretty quickly. Really, it's more the shoulders, scapular stabilizers, which is really going to probably be that determining factor. But we don't have amazing assessments for that. So coming up with something that might be some sort of objective metric would be really helpful. Then two, the psych readiness, like I was speaking about before. We have a start with that test, but need to be validated further and probably made a little bit more robust. And then from a technical standpoint, I just think this is awesome and I'm badass for doing it. So here's a picture of what's called an arthroscopic DTA. So we talked about two types of surgeries in general. One is a purely arthroscopic surgery that fixes the labrum. One was an open surgery that puts more bone in the shoulder. This is the marriage of the two, where arthroscopically you put more bone in the shoulder. Technically, it's challenging, but I've now done quite a number of them, and I've been really, really happy. I think my guess is this will be the future of all shoulder instability surgery, but it's just hard. So we all have to, as a community, learn how to do it. So in summary, return to play after instability. It's controversial. There's both time and functional components. This really, really requires individualized treatment. Probably, I think, potentially more than my ACL patients, because sport type is so different in terms of an overhead thrower versus a contact athlete versus, a tennis player is going to be very different. Timing's different, goals are different. You really have to get into the nitty gritty with them, and it's a lot more nuanced than just 6 months you're good to go. Remember psych readiness. This is really traumatic for them. It's going to take a lot for them to get back to playing, both functionally and mentally. And then shared decision making. I know that it seems like a cop out when people say that in talks, like you got to talk with your patient, but especially given our lack of clarity on a lot of these things, it's there's no right answer to most of these decisions, and it's going to be up to ultimately the patient. It's our job just to give them those risks and benefits. And, like I said, it's not an excuse. You're not just not helping them. You're not telling them, you're not just being patriarchal. You're letting them make the best decision for them, and they're probably going to know that best. Thanks.
Dr. Kaplan, your talk was phenomenal, and we we all know you're a badass for sure. Yeah, you can't say it. I mean, that's just known. That's a factoid. Yeah, no, really, a really great talk by everybody. Uh, and while we're tabulating all of your questions, and please, ask some more. If you send it in, we'll see your questions. So please, any of the questions that you might have, please send them in at this time. And while we're putting all those pictures, questions together, maybe we'll just spend maybe just 5 minutes just to hear about our expert panel and just a little bit about orthobiologics and maybe how you make your return to play decisions. Since we're really talking about sports and decisions and controversies in sports medicine, why don't I start with Dr. Apicella? Dr. Apicella, and just general guidelines, right? Not specific, because I have a feeling, it's quite interesting, and we did not talk about this at all pre-conference, but I have a feeling we may all be in some different places when it comes to this. But in terms of just in general rules that you use, and let's be quite specific then, let's say PRP injection, and let's say a 30-year-old PRP injection tendon for a chronic tendon problem. What's your advice about timing and getting back to sport?
Yeah, for sure. So I'm actually pretty interested to see what everyone's different take is, because we didn't really talk about it beforehand. But for me, for someone that where I'm doing an injection into their tendon, I'm a little bit more cautious, right? And so because we do kind of cause a little bit of an injury to the tendon as we're poking through it and kind of checking it, I may have them kind of, let's say if it's an upper extremity, um, tendon, I may have them protect it for a couple of days, really try to get them to not overuse it for a few days. And then over those next couple of days, they can kind of wean out. If I give them a sling or something like that, they can kind of come out of that sling. I'll tell them to kind of get back into kind of gentle range of motion over the next 2 weeks or so, and then really not get into any kind of gradual strengthening until about 4 weeks or so, really. And then if they have no pain and full range of motion around that 4 to 6 week time frame, they can try to start getting back into their activity. But a lot of times I'll let them know that it can take longer than that 6 weeks or more to really kind of get back to full strength and back to full play. Uh, and everyone's a little bit different from the ones I've seen. I think you're muted, Dr. Cardone.
So sorry. Yeah, I had some New York City traffic going by. I needed to mute. Dr. Lott, yourself, PRP guidance, instructions to patients, PRP soft tissue.
Yeah, I'm similar to Dr. Apicella. I think that a lot of times people, you really need the downtime after the PRP, to let it work and to kind of calm everything down. I think you kind of run into problems when you do the PRP and then they're going back and strengthening right away, and you need that time for for those biologics to work. So I'm in the same camp as Dr. Apicella.
Yeah. How do Ariana and Apicella, how long did you guys say? I had to move out of the auditorium because they're cleaning the rug.
We said for like full strengthening for a tendinopathy, if you're injecting into the tendon, like 4 to 6 weeks for full strengthening back.
Into the tendon directly, yeah, I'd probably be about the same. But what would you guys say for like just a joint injection?
For joint, I would be fine with it much sooner.
Yeah, yeah, same,
Yeah.
same.
It's just if you're Yeah, if you're doing it into the tendon and like Dr. Apicella said, if you're causing like any sort of micro trauma or anything like that and waiting for that biology to heal, I think that that takes a longer time.
Yeah. Okay. I agree.
Yeah, and I would agree with everyone. And the only thing that I would say is in the years that I've been doing it, I have become, and I think most of us potentially, just a little bit more aggressive with our return to play after, in general, PRP. I remember when first started, whenever that was. It seems like yesterday, but it's probably already about 8 to 10 years. And I remember we were waiting as long as 8 weeks. And now, just like you're saying, there are some joint and even tendon problems where, depending how symptomatic they are or they aren't, will also be guide and obviously return to age, activity that they're doing, how aggressively they're going to get back to sport. But I do certainly have a population that I will say no strenuous activity for a week, and there are even some that I'll let return to some degree even after just 1 week, right? But always explaining that they should be at least back to their baseline. They're not irritated from the PRP, and that's still going to take, as we know, sometimes 7 to 8 weeks before they may see positive results. So I think I thought there was going to be some controversy. I think we're all similar.
I think we all are just nervous about injecting a tendon and letting someone go and rupture that. That would be bad.
Sure. That's in the not good column. Okay, let's get to some questions from our audience. Here's one. Let's start off. Dr. I'm sorry, Dr. Lott. This is for you. From we know her well. Her name is Anonymous, and Anonymous writes, if ACL graft ligamentization takes 12 to 24 months, why don't we wait at least 12 months for return to sport instead of 8 to 9 months?
Yeah. So I mean that's the question. And one of the papers that I brought up there was people asking about 2 years, because we can even see changes up to 2 years. Um, that's definitely a controversy. I think personally, the literature shows in terms of time clinically that that big jump of whether or not you have a higher rate of re-tear is around the 9 month part. Some people take 12 months just for their strength and everything to get back. So that's why I personally, based off of the clinical research, use 9 months. But that's a controversy that people still talk about. So that's a great question.
You know, and I'm just going to piggyback that question with also coming in at a question. You said non-elite athletes, about 40 to 60% get back to their prior to surgery level of play, and
Yeah.
83% of elite athletes get returned to their pre-injury level. And now, is that because the subjectivity of the question is that more, you think, psychological related, or pressure just to get back to sport, or why is there such a big difference?
Well, I mean, I think it's a little bit of both. Some is the psychological of, um, I injured myself while playing football, and I graduated high school, and now I'm going off to college, and I'm not going to play football anymore. I'm going to do X, Y, or Z sport instead. And so they may not just return to that because they don't want to. They may return to that because it's a different phase of their life, or they may not return to it because they're not able to. So it's hard to kind of piecemeal that. In terms of elite athletes, I mean, it's their usually it's their job to get back to doing the sport that they want to do, and they have a lot more support around them to do that. So I think that reflects the higher numbers in terms of our elite athletes.
Fantastic. So for Dr. Apicella, could you just talk about maybe how upper extremity VTEs present? so as not to be missed in practice.
Yeah, for sure. So obviously there is kind of more obvious signs that we might see for an upper extremity DVT. So swelling that you start to notice in the upper extremity, you can look for dilation or lateral vein. So you'll see kind of this bluish discoloration over the anterior shoulder, and you'll see those veins kind of really dilate there. Um, and then if they don't have a history of like some sort of strain or injury that can kind of cause this kind of pain, then I start to have a higher suspicion for it. But it's really more so looking for this kind of noticeable swelling or vein dilation is what usually I'll look for, or the literature supports looking for.
All right. Dr. Kaplan, when you're talking to the under 18-year-old, say the high school athlete with first time dislocator, um, how do you approach parents and athlete and speak to them, and maybe sometimes they might have different views. How do you approach that? A first time dislocator, high school athlete with parents and athlete.
I just tell them I'm right and they're wrong. That's fine. So that's the $1 million question now. All of the evidence is now pointing more and more towards that person having an incredibly high risk of recurrent dislocation if they're not treated surgically. On the other hand, it's really hard to convince a patient, an athlete, their parents that, they pop their shoulder out, it's back in place, they feel great now, and now they need that fixed. That, potentially, 6 months of their life is going to be changed versus saying, well, we can just try PT and see how it goes. And if it happens again, then we have to fix it. They, always unequivocally prefer that response. When I first started, not, it's only 2 years ago, but I was much more on that side of the coin where I would say, there is a risk, but there's probably nothing wrong with trying PT and seeing how you do. And if it doesn't work, we can always fix it in the future. I still think that's a totally reasonable approach, but I am a little bit more, I would say I have a little bit more of a discussion now truly about what that recurrence risk is, just to let them know what they're up against. So I would tell them they're based on their age, they probably, and if they're playing a sport, particularly if it's contact, they probably have between a 50 and even 65% redislocation rate. That if they just treat that non-operatively, that can happen at any time in an uncontrolled manner. If you treat that surgically, when you want, you can pick and choose exactly when you have that surgery, get them back with confidence that they can play hopefully the rest of their athletic career without any trouble. So I lay that out for them. I now at least get an MRI basically after every first time shoulder dislocator in a young athlete, just to see it, if there's anything that's puts them at particularly high risk, like for whatever reason they have a certain type of labral tear that isn't worth getting into now, that puts them at almost 100% risk, or they have a massive Hill Sachs or something like that. So it just about I'm a little more forward with the information now than I was, is how I would best describe that. Ultimately, up to them if we disagree. There is no, it's not about agreement or disagreement. I would just say it's about giving them all of the information and letting them decide what type of risk they want to accept.
Yeah, no, it certainly seems in this day and age that we're almost all committed to at least X-ray and MRI after a first time dislocation for sure. Yeah. Hey, does handedness ever come into any decision making when it comes to dislocation?
It does, either handedness and then that going in part with their sport. So, like, let's say they're a tennis player and they're right-handed and it's their left shoulder, the odds of them dislocating that again are much, much lower than if they're dominant shoulder and they're serving. So I know tennis is near and dear to your heart, so I keep harping on it. Um, so yes, handedness does play a pretty big role in that. And just part and parcel with all of what we would discuss, where it's very patient centric, and everyone needs their own tailored treatment plan.
Dr. Lott, a question for you. It's about tennis. No, no, it's not. But Dr. Lott, we have been using force plates to start assessing counter jump movements, side to side jumps, etc. Gives us a lot of information on concentric strength, eccentric strength, which has shown strong correlation for athletic movement. Any thoughts on additional functional testing for return to play?
Yeah, I mean, I think that there's a whole gamut of different testing that can be used. I think the more things that we test, the better. I think that so that the force plate analysis that you mentioned, I think that sounds great. I think that we've shown so much in the literature about biomechanics and valgus landing biomechanics and the risk of individuals and first time ACL tears and second time ACL tears, and I think that all of that information is great. I think the difficult part is how do we validate these tools, and then also it sounds like you're at a pretty high level center if you're using force plates to analyze your athletes, and so treating patients of how do we do return to sport testing, from a national level, people that don't have access to some of the amazing work that it sounds like that you're doing. So I think that's a great idea. And I'm not sure that I answered the question, but or instilled more controversies.
All good. I'm going to throw this out to here's a question for the whole group. Is there a role for PRP in repeat stress fractures? And I'll open it up without answering the question directly to say we're certainly using shockwave treatment, ESWT, more and more for some of these stress fractures that we're struggling with healing. PRP, and any thoughts? I throw it out to the three of you. Using PRP for stress fracture, not something that I do commonly. So as I'm answering the question, give you all time to think.
I
Um,
I haven't even heard of that before. I mean, sure. Yeah, let's 5 sessions, 5 PRPs, $900 a pop. Let's do it. I would say, and then probably once they're healed, we should probably do another 5 just to be safe, and possibly in the other side too. So yes, no, I haven't heard
Let me write
that.
that protocol. Let me write that protocol down. But where I've used it is medial tibial stress syndrome, like chronic medial tibial stress syndrome, and injecting along the medial tibia. And I've actually had some fairly decent results. Of course, I'm giving you anecdotal results, but again, have not had any experience using it for stress fractures. Apicella, that's a lot. Anything?
No, me neither. I haven't used it for stress fractures. I agree. I think reaching for like a focused shock wave makes more sense to me before doing a PRP injection.
Yeah, I also haven't used it. I mean, the only thing is that we use it in fractures that don't heal for added biology. If we go in and fix them surgically, sometimes we use like PRP versus BMAC, other types of biologics to supplement that area. So it's an interesting thought. I've never seen it done or personally done it in my practice.
We all will now.
All right, here's the last question. And I like it. It's a straightforward, and it's for Kaplan. Kaplan, this is what it says. So, what's the board answer for treatment of a first-time shoulder dislocation? Surgery or no surgery? Board answer. You got A or B?
There's no board answer. I'm gonna say the right answer, if they're young, is surgery.
Certainly swinging in that direction for sure, right? Young first-time dislocator.
If they're an athlete, if they're playing first time dislocator young, I would, of course there's no real right answer, but I would at least strong in really make them aware of the risks of not having that fixed.
To all our speakers, what unbelievable talks that you've all given. Thank you so much for joining us. Really great information on a really wonderful topic that we all sometimes struggle with, seeing our sports athletes. Thanks so much for joining us. And for all of our attendees, we really appreciate you very much attending. On behalf of the orthopedic department at NYU Langone and all of NYU Langone Health, thanks so much for joining us. We look forward to seeing you all back at our next webinar. Everyone have a safe and good evening. Get home safely.
Thanks, Dennis.
Thank you.
Hey, thanks.